I'll go ahead and share my screen. All right, you can all see the PowerPoint not in presentation mode. So this is normal mode for you all, right? Okay. All right. Yes, thank you. As Dr. Morgenstern said, my name is Matt. I'm one of the PGY-2 junior residents, and I just finished my pediatrics rotation last block under Dr. Morgenstern and Dr. Katan. So I wanted to share a interesting case, which I learned quite a lot from during the patient's time here, and hopefully the rest of you all can learn something from this as well. I have no disclosures. So this is a 5-year-old, previously healthy female who presented to the emergency room, referred from her GI doctor. She initially had 3 months of vomiting, had extensive outpatient GI workup, and then over the past 3 days had worsening headache, double vision, and gait instability. And her mom also noticed some twitching episodes of her arm and face the night before. On our initial evaluation, she was awake but drowsy. She did have diplopia and she had an ataxic gait, but otherwise she was neuro intact. So Noah, if you were the resident on call, hearing the story and seeing this patient, what syndrome, I guess, are you most concerned about in the immediate term?
Yeah, so overall concerning case. She has difficulty with ambulation, worsening headaches, double vision. I would be most concerned about hydrocephalus in this young patient. So I guess initial steps would basically to actually see what her ventricles look like. She should get a CT scan.
Right, absolutely. Yeah, CAT scan, quick, easy, and worth the radiation risk given this concerning story. So this is what her initial CAT scan looked like. Brandon, are you able to take us through this cut of the CAT scan quickly?
Yeah, axial cut of CT non-con. First thing, looking at the ventricles, you can see that the temporal horns are enlarged. The third ventricle is enlarged and bowed out, suggested that there's a hydrocephalus process going on. Looking into the posterior fossa, there appears to be some kind of midline mass, maybe causing an obstructive hydrocephalus.
Absolutely. Yeah, definitely a concerning CAT scan. So the next step for this patient, Brandon, what do you want to do?
In someone that's acutely worsening over the last few days, they should get CSF diversion, EVD. Absolutely, yes.
So the most pressing issue for her is not the mass, but definitely the hydrocephalus causing her symptoms. So a category 1 was called that night, and she was taken for a navigated right frontal EVD, and she was under very high pressure. The ICP was above 30 centimeters of water when the catheter was first placed. And then she went to the PICU with the EVD open at set to drain at 20, and was doing well after the initial EVD placement, fortunately. So now, Abhi, what other workup do you want for this girl?
So since we addressed the acute problem of hydrocephalus, I think now we can move on to the cause of hydrocephalus, which is most likely the mass lesion in the posterior fossa, from what we can see in the CT. So an MRI brain.
Absolutely. Would you want any other imaging while she's down there for the brain?
Can you hear me?
I couldn't. I don't know if other people could.
Oh, great. Sorry. I was going to say, since we acutely address the issue of hydrocephalus, the next step would be to get an MRI of the brain with and without contrast to further assess what seems to be the cause of the hydrocephalus, which from the CT is in the midline lesion in the posterior fossa.
Yeah. So we got the MRI brain, and it shows just for time, on the sagittal and axial cuts. These are post-contrast. It has this, sort of weakly heterologically enhancing mass. and then there was some diffusion restriction in the mass as well. We also got a spinal survey while she was down there just to look for any spinal lesions. Unfortunately, that was negative. So differential diagnosis, Avi, what's top of your differential here?
All right, so the posterior fossa mask in a pediatric patient, a few things on the top, especially in her medulloblastoma, ependymoma. Other common ones would be pilocytic astrocytoma, which just doesn't look like the typical other ones. The brainstem gliomas can have choroid plexus papillomas. ATLT sometimes.
ATLT, excellent. Yeah. So just like the classic teaching is that 70% of pediatric tumors are infratentorial. And the most common ones are, I think, the first four you mentioned. These percentages are from CITAL board review, so I don't know how accurate they are. I've seen different percentages in other literature sources, but astrocytoma, brainstem glioma, medulloblastoma, and ependymoma are the four most common. And a handy mnemonic to remember them by is BEAM. All right. So now we're surgeons, so we took this for surgery. But specifically, is Alex here? I know he was dealing with a patient. Alex, is there any particular risk or complication you'd want to counsel the parents on?
Yes. So posterior fossa syndrome would be kind of the primary concern, not uncommon in pediatric brain tumors after resection. This could present different ways, but commonly a mutism. Could also have some post-op ataxia, dysphagia, etc., as well as the regular risks of infection, bleeding, risk of CSF leak or develop of a meningocele, etc. But posterior fossa syndrome would be the big thing I would talk to the parents about.
Definitely. So the posterior fossa syndrome or cerebral mutism, as you nicely said, often presents with mutism, or issues with speech production, dysphagia, ataxia, and hypotonia, then also emotional lability and sometimes urinary issues as well. It can be seen up to 25% of patients after medulloblastoma resection. So definitely something that's pretty common. And the symptoms, while transient, they can last for months, and there are some aspects which can be permanent. There can be long-term speech and long-term behavioral issues from the posterior fossa syndrome. So we took her, she came in on a Friday night, I believe, and she was taken to the OR for resection on Monday. And we did a suboccipital craniotomy and C1 laminectomy because the tumor did extend pretty far inferiorly. And we did this through a midline transfemoral approach, which gave us great access, but can increase the risk of cerebral mutism to go transfemoral. Intraoperatively, the tumor was soft, very hemorrhagic, and it was adherent to the brainstem. We sent a frozen, which was non-diagnostic, but they were able to clarify that it did not look highly cellular to us. So that lowered our intraoperative differential from medulloblastoma. This is a representative histology slide of medulloblastoma here. The classic small round blue cells, very highly cellular. So the tumor looked less likely to be medulloblastoma, and that did actually change the aggressiveness with which we tried to get gross total resection intraoperatively. So here's a couple of intraoperative pictures, courtesy of Dr. Morgenstern and Kurt, who are also in the case. So this is right after the dural opening, and you can see the mass pouching out here just below the obex. And then this is after we made part of the transfemoral approach and during the tumor resection. And then this is a really beautiful case for intraoperative anatomy, especially for the floor of the fourth ventricle. Alex, do you know what we're looking at here with these white lines?
The stria medullaris.
Yeah, exactly. It's a beautiful picture of the stria medullaris, and We were able to see quite a lot of the other anatomy as well, but I think the pictures I saw at least didn't look quite as beautiful as this one, I think, of the stria medullaris. So I thought it was really interesting. And just a reminder of some of that pertinent anatomy. The stria medullaris here, and the facial colliculus, the vagal and hypoglossal triangles, slightly more caudally. So all of which are important to know because they can cause, postoperative problems in these patients. So she woke up initially fully oriented, full strength. She was doing quite well. The tumor was hemorrhagic, so we got a postoperative CAT scan which showed expected ventricular blood. And fortunately, we already had the EVD, and we kept that open to drain at 5 centimeters of water for the first few days. We got an MRI brain on post-op day 1 showing gross total resection, as seen here. She initially did quite well, but then a couple days later, started developing posterior fossa syndrome. She was very dysarthric. She was able to say her name, and she would say yes or no, but not much else. And she was very hypotonic. At one point, she could sort of just barely shrug her shoulders. She did require an NG tube for a prolonged period, and she was very irritable and frustrated throughout the rest of her hospital stay. She also had a pretty dense left facial palsy and some abducens palsies and restricted extraocular eye movements, likely due to the involvement of the fourth ventricle. However, the intraventricular blood quickly cleared. We were able to successfully remove the EVD. Then the pathology returned as ependymoma, WHO grade 2, and posterior fossa group A. It was sustained positive for GFAP and EMA, as expected for an ependymoma, and it was H3K27M negative, which is what defines a posterior fossa group A tumor. They also sent it for particular molecular genetics. It was absent for a 1Q gain, which is commonly seen in posterior fossa group A, but it was positive for a 6Q loss, which we'll talk a bit more about in coming slides. Just briefly, ependymomas are glial tumors that arise along the ependymoma, as in the name, and they arise from these radial glial stem cells. They can occur anywhere along the neuraxis. They're most commonly in the posterior fossa. I was seeing about 60% or so quoted as being in the posterior fossa. And the current WHO classification as of 2021 separates ependymomas by their location into supratentorial, posterior fossa, spinal, and also myxopathy and subependymoma. And these tumors all differ molecularly and how they behave by location. They're either WHO grade 2 or 3, with grade 3 being slightly more aggressive and having more frequent mitoses and endovascular hypoplasia characterized on the pathology slides. Myxopapillary ependymoma is now a WHO grade 2. I remember back in med school, I think I learned it was a grade 1, so I thought that was an interesting update. And then the histology to be aware of as we're getting to board season is that we often see these ependymal rosettes, which are pathognomonic, but they're actually not that common. Here's an example of what that might look like. More common, but not pathognomonic, are paravascular pseudorosettes, as seen here. They quite often can have dystrophic calcification, and then stains you might see GFAP, EMA, S100, and Vimentin positive. So posterior fossa ependymomas in particular, they mostly arise from the fourth ventricle, which makes sense. And they often extend through the foramina of Luschka or Magendie, and they commonly present with hydrocephalus due to obstruction of CSF outflow, as seen in our patient here. Their imaging is quite heterogeneous. I think our patient's tumor was slightly heterogeneous, but they can have calcifications as seen pathologically, but can also be seen radiographically. They can present with hemorrhagic portions or necrotic portions or even cystic portions. And on MRI, they're often T1 hypointense, T2 hyperintense, and heterogeneously enhancing, but they can also have diffusion restriction as well. Posterior fossa A tumors, as in our patient, tend to present with a younger age of onset. So the median is about 3 years. Very rarely are they found in adults. Adults make up less than 15% of posterior fossa A tumors in literature that I was reading. And they're very poor prognosis, unfortunately. of all the ependymoma subtypes listed in the current WHO grading, theirs is the worst prognosis with about a 70 to 80% 5-year overall survival. There is a male predominance, about 65 to 35% males to females. And location within the fourth ventricle, they're more likely to arise in the lateral recesses, about 2/3 laterally, 1/3 medially, although in a very large tumor, such as our patients, I think it's probably hard to tell exactly where they arise. And then the positive prognostic factors in posterior fossa A are gross total resection, upfront radiation therapy to the surgical bed, and then a Ki-67 index of less than 10%. Molecularly, they're characterized by loss of H3K27, as seen in our patient's pathology. This is involved in histone methylation processes, and it's a current target for sort of new treatments, targeted treatments of posterior fossa A ependymomos. They're pretty chromosomally balanced in general, but they can have occasional chromosomal alterations, most frequently the 1q gain, seen in about 15 to 20% of patients, or the 6q deletion is the second most common, seen in about 6 to 8% of patients, both of which are poor prognostic factors. The 6q deletion in particular is an especially poor prognostic factor. And then there are 9 different subgroups of posterior fossa A tumors alone, just based on molecular genetics. So we're sort of constantly finding new molecular components and constantly changing the definitions of these tumors, it seems like. The tumor microenvironment for posterior fossa A is highly inflammatory, characterized by a lot of IL-6 and F-kappa B. This is a recent study by the Toronto group, I believe, just showing how these 1q and 6q chromosomal alterations affect survival. So the blue line here is sort of your wild type, where they do not have the 1q gain or the 6q loss. And you can see they have the best survival. The yellow is 1q gain alone, so a worse prognosis than if they did not have that 1q gain, but better than if they have the 6q loss. And these last two ones are the ones that have the 6q loss, and they have unfortunately a much poorer prognosis. And sadly, our patient's pathology did return with the 6q loss. Posterior fossa B, on the other hand, are typically an older age of onset, more adolescents, young adults, more commonly in adults with a median age of about 30 years. And they have a much better prognosis with a 5-year overall survival, often well over 90%, up to like 98, 99%. They have a slight female predominance, and they are more likely to arise from the floor of the fourth ventricle near the obex, with about 90% arising medially within the fourth ventricle. The positive prognostic factors are, again, gross total resection and a lower Ki-67 index. Interestingly, radiotherapy for these tumors has not as clearly been linked to be a positive prognostic factor, and that has led to, I think, a current clinical trial whether or not they may consider not radiating these tumors, just given the morbidity associated with radiation to the posterior fossa. Age at diagnosis is also non-prognostic for posterior fossa B tumors. They're characterized by FOXJ1, which is associated with the sonic hedgehog signaling pathway, and it regulates ciliogenesis, which is highly expressed in ependymal cells. They are often very chromosomally imbalanced with frequent 6p and 6q deletions. Interestingly, 6q deletions here, while they are a poor prognostic factor, they're not as prognostic as posterior fossa A. And sort of overall global studies looking at 6q deletions in posterior fossa ependymomos say it's a good prognostic factor, because it's not until you stratify between posterior fossa A and posterior fossa B that you really see the deleterious effect on survival in posterior fossa A tumors with the 6q deletion. And there are fewer subgroups than posterior fossa B tumors. The current treatment guidelines, gross total resection, and then upfront radiation therapy to the surgical bed with 54 to just under 60 grays of radiation. However, as I mentioned, we are currently investigating de-escalation of radiation to posterior fossa B tumors, given the limited survival benefit with it. Chemotherapy has less of an established role. However, given the poor prognosis of posterior fossa A tumors, there are a number of trials looking into chemotherapy and sort of newer therapies to try to increase the survival of posterior fossa A especially. And here's a handy table sort of summarizing everything I just said with the posterior fossa A and B tumors. And just to quickly wrap up what happened with our patient. While an inpatient, she had a LP, which was negative for cytology, fortunately, after surgery. And she was discharged to rehab about 6 weeks after her initial presentation. She's currently undergoing radiotherapy, I believe with proton beam therapy. And on follow-up a couple weeks ago, her posterior fossa syndrome is greatly improving. She's now talkative, ambulatory, her swallowing is improved, and her personality is greatly back to normal. She does still have a dense left facial palsy, and she has seen ENT, I believe, Dr. Rosenberg, for possible facial reanimation in the future. And once she finishes radiotherapy, she is going to undergo adjuvant chemotherapy, given that 6q deletion in the poor prognosis that comes with it, with vincristine, etoposide, cisplatin, and cyclophosphamide to try to increase her chances. References. All right. Thank you to Dr. Morgenstern, who was the attending on this case and helped me out with some recommendations for the slides as well. So I'll turn it over to him, or if any of you have any questions for Dr. Fifi.
Just a couple quick comments. Matt, nice job with this. I think this really illustrates well that the field of molecular pathology for pediatric CNS tumors has really rapidly progressed. And at least a rudimentary understanding of it as a neurosurgeon is important, both for intraoperative decision-making and participating in the care of these kids afterwards. If I could have the residents take one thing away from this case, it's that a basic understanding of the histopathology and the outcomes of each of these tumor types will help you make decisions in the OR. So knowing that if you leave behind a carpet of tumor for a medulloblastoma, it does not profoundly affect long-term survival, whereas leaving behind any tumor in an ependymoma will dramatically affect their long-term survival. Helped us decide how aggressive to be in the OR once I heard what the frozen path looked like. And although they told me it's non-diagnostic, they were able to give me enough information that made me suspect that it was an ependymoma, along with its attachment at the foramen of Luschka. Putting those pieces together helped make those decisions. So this is why it's on your boards. It's not just there as sort of fluff that you have to memorize and then forget. You really do need to use it in the future.
Hey, am I okay to make a comment here? Can you hear me?
Yeah.
Matt, nice work. Peter, great job on that case. I wanted to just highlight a few of the things that you've talked about in your presentation, Matt, starting with the comment that at the beginning in the workup reflects a very prevalent perception out there in the culture of the emergency room, the culture of the pediatricians, and also the culture of all of us who first greet a patient, which is this so-called risk of CT scanning. In my experience, over the last 10 years, I've seen far greater risk associated with not getting a CT. The risk of CT in this age group with a low dose protocol that's used in the Mount Sinai health system is exquisitely low. And the gain, which is to figure out what's going on expeditiously, is so important. So I would challenge all of us to go and look at the literature on so-called risk of CT and make sure to educate our colleagues in the emergency room or in the NICU, for example, where there's a very, very high reluctance to get a CAT scan. And you can't see some things on ultrasound like bilateral epidural hematomas after birth injury with an ultrasound, and those can go missed and misdiagnosed. And it's so simple to go down and get a CT. And sometimes it's very difficult to get an ultrasound on the weekend. So it's just so important to disabuse people of that myth that it's too risky to get a CAT scan. JB, back in the 80s and 90s, nobody hesitated to get CTs. We got them, like they were giving out candy. Then there was this culture shift that we said, oh boy, there was a study out of Sweden that said that one CT could harm a toddler. Come on, this is a real world problem here that we misdiagnose, we don't get an accurate diagnosis. That's one. In posterior fossa syndrome, my experience has been disinhibition as one of the very, very common and troubling behaviors that the kids have. They become disinhibited. They say things that a longshoreman might say, and it surprises their parents. They don't know where these swear words came from, but it's very troubling to parents, and they need to be reassured that that'll go away. What do you do, Matt, to prevent intraventricular blood? You said, quote, expected intraventricular blood. What would you do to try to prevent it?
I mean, I think the key is just close attention to hemostasis intraoperatively.
Sometimes you can't. So what do? When you get a view of the aqueduct, take a big piece of gel foam. And the reason I say big piece of gel foam is because you don't want a little piece to go up there and get stuck or get stuck in the third ventricle. Put a big piece of gel foam at the inlet of the aqueduct. That's one thing. I really appreciate your molecular overview because it reflects how far we have come in terms of understanding these pediatric brain tumors, but the perspective remains the same from my years in pediatric neurosurgery, which is that in most of these diseases, the surgeon plays the primary role here in determining the outcome. And kudos to Peter for being aggressive with that resection, because that gives her the best chance at survival. And yes, you don't want to go digging into the brainstem on a medulla, and you know that your chemo could be effective there. But in a JPA even, you save that family years of heartache and anxiety by getting a gross total resection. In ependymoma, you save their life by getting a gross total resection. And I would say those are the risks that have to also be discussed in addition to posterior fossa syndrome. Talk about what the surgeon has to do in that initial operation to give the child